Hello, everybody. Welcome to Grand Rounds. We are delighted to have with us Dr. Minal, who is an assistant professor of medicine at ICON and a primary care doc, came here for her general medicine fellowship and has stayed on and now funded by American Cancer Society and the NIH to do research on lung cancer screening. And that's what she's going to be joining us to talk about today. Dr. Kale.
Hi, thank you. You nailed the pronunciation of my name, so thank you. Good afternoon, everyone. It's nice to see all these boxes. It's really great. And thank you so much for inviting me to present today. So let me go ahead and try to share my screen and we can get started. Oh. Okay, can everyone see my screen? Okay, great. All right, so here is the title of today's talk, Barriers to Lung Cancer Screening, What is Stopping Us? I have no conflicts of interest to disclose. So here are the objectives for today. We're going to start by reviewing the current lung cancer screening eligibility criteria. I'm also going to talk about the benefits and harms of screening, followed by assessing promising novel lung cancer screening criteria. And then lastly, we'll explore system provider and patient barriers to screening. So let's start with the scope of the problem. Lung cancer is the leading cause of cancer death in the United States. And you can see that lung cancer deaths are higher than colon and breast cancer deaths combined, which I think most people don't necessarily appreciate. And you can see here the 5-year survival of lung cancer, which is around 21%. And this is again compared to colon cancer, which has a 5-year survival of 65%, followed by breast cancer, a 5-year survival of 90%. And crucially, the 5-year lung cancer survival varies by stage. So you can see the top line here is the 5-year survival for stages 1 and 2, which has a 5-year survival of 58%. Stage 3 is lower, it's around 30%. Stage 4, sadly, is around 5%, and then gives us an average of about 20%. And unfortunately, just over 20% of lung cancers are diagnosed at an early stage. So I think we all know that smoking prevention and cessation are the most effective interventions in reducing lung cancer incidence and mortality. We know that smoking is the cause in about 85 to 90% of lung cancers. And I want to bring your attention to these images in contrast to these media images from this image from the 1950s, when doctors were actually regularly featured in cigarette and tobacco ads, kind of touting the health benefits of smoking. So we have come a long way. And we have good news. So smoking prevalence is decreasing. So you can see here in 1965, smoking prevalence was around 42%. In 2017, smoking prevalence has decreased to 14%. So in addition to anti-smoking public health messages to decrease lung cancer incidence, we also have lung cancer screening. And this is important because it's an opportunity to detect lung cancer at an early stage when there are surgical options that are available to cure lung cancer. So now this brings us to the first objective of today, which is to review the current lung cancer screening eligibility criteria. So this is kind of a busy slide, but stay with me. So this slide presents the eligibility criteria according to these different organizations. On the left here, you see the USPSTF, American Cancer Society, CMS, and NCCN guidelines. And roughly the age ranges are similar between 55 and 80, or slight differences on the upper end of that. And then the smoking history, again, is all pretty much the same, 30 pack years and that's for current smokers, or if they're former smokers, they need to have quit within 15 years. And you can see, I just want to draw your attention to the NCCN here at the bottom. They have 2 categories for people who are considered high risk and should be receiving lung cancer screening. So the first one is 55 to 77, similar to the other organizations. And then they also have, they consider this high risk group of people over the age of 50 who have 20 pack years and have risk factors. And they consider risk factors of family history, radon and asbestos exposure, history of cancer, COPD, and fibrosis. And then, lung cancer screening is also recommended in the context of both shared decision-making and then offering smoking cessation. And that's recommended kind of across the board. So now let's move on to talking about the benefits and harms of screening. And I think it's difficult to talk about lung cancer screening with CT without first talking about some of the work that was done by Doctors Henschke and Yankelowitz of Mount Sinai, who have led the ILCAP program for the last many decades. And they really gave us some of the earliest evidence supporting lung cancer screening. They've been conducting studies on CT screening for lung cancer for decades, and they've found that screening with low-dose CT increased early-stage diagnosis compared to usual care. And this work has been very influential in helping to understand the diagnostic performance of a screening regimen, as well as exploring alternative thresholds. And of course, data from these cohort studies has been significantly robustly strengthened by data from RCTs. So you can see on the left here, we have the New England Journal of Medicine paper for the NLST trial, which is one of the first very large RCTs of over 50,000 participants, and in whom they compared low-dose CT compared to chest radiography and found a 20% relative reduction in lung cancer mortality. And also you see on the right here, the New England Journal of Medicine paper for the Nelson trial, which is another large RCT, not quite as large as the NLST, that was conducted in Europe. They had about 15,000 participants, and they compared 4 rounds of CT versus standard of care. So they weren't necessarily comparing to chest X-ray. And after 10 years of follow-up, they too found about a 25% relative reduction in lung cancer mortality. So this is the whopping evidence that we have. Unfortunately, US lung cancer adoption is pretty abysmal. So in 2013, you can see this is when the USPSTF, a mouthful. USPSTF recommended screening, and you can see that unsurprisingly, it was around 3%. And now in 2018, it's only risen to 17%. And this is, in spite of that fantastic evidence from RCT showing that lung cancer screening reduces lung cancer mortality. And we found this adoption rate by looking at the BRFSS, which is a telephone health survey of US residents that provides state level data related to major health conditions. And we looked at 2018 BRFSS data and measured self-reported annual low-dose CT imaging for lung cancer screening among individuals who are eligible for screening, according to USPSTF criteria. And importantly, I just want to note that these questions for lung cancer screening were not even adopted by all 50 states. So only 8 states adopted these lung cancer screening questions. So that just shows you a little bit of how low the traction is in terms of understanding the importance of lung cancer screening. And then interestingly, you can see that US lung cancer adoption varies by state. So it is an all-time high of 24% in Texas, which is fantastic, but still only 24%, compared to the lowest in Maine, the state of Maine, where only 8% of eligible individuals have received lung cancer screening. And again, this is just in contrast to mammography and colorectal cancer screening, where we see nice high rates of 70%, and that's for the past at least decade. So perhaps some of the poor adoption of lung cancer screening has to do with the harms of lung cancer screening. So here you can see that we have the harms of false positives, incidental findings, anxiety, and overdiagnosis. And these are harms that aren't necessarily unique to lung cancer screening. You'll find very similar kind of big themes or categories of harms if you consider breast cancer screening as well. But of course, the nuances and the details are different in lung cancer screening. So we're going to go through those a little bit. Let's start with false positive results. So in the NLST in round 1, 26% of scans were false positives, and then this declined to 21% in subsequent rounds. So that's actually a pretty impressive number of false positives and very alarming. But the good news is that the thresholds that they use to determine a positive scan in the NLST are different from what we now use. So we have different positivity thresholds. And when investigators retrospectively applied the current or contemporary positivity thresholds to the NLST data, they found that that actually changed the frequency of false positives to about 13% in round 1 and then down to 5% in subsequent rounds. So that should be pretty reassuring. And then incidental findings. So these have ranged from 6 to 15%. And you can imagine that imaging of any kind is going to pick up other abnormalities that are going to then lead to, a cascade of diagnostic evaluation and testing. So they range from 6 to 15%, including things like renal cysts, thyroid abnormalities, hernias. So anxiety. So studies have found that screening does cause psychological discomfort, but that this is short-lived and that it did not affect distress, worry, or health-related quality of life. And then the last harm that I'd like to focus on is the harm of overdiagnosis. So what is overdiagnosis? So overdiagnosis is a consequence of screening. And this picture is really meant to just help us understand what overdiagnosis is. So here you have this former smoker. In the first scenario on top here, they develop a slow growing lung cancer. They also meet eligibility criteria and undergo lung cancer screening. That lung cancer is then diagnosed and the person is treated, perhaps surgically. And then they ultimately go on to die of a non-lung cancer death. And then in the second scenario, the same former smoker who also develops this slow growing lung cancer, also goes on to die of a non-lung cancer death. So the diagnosis of this cancer that would otherwise not cause symptoms or harm to a patient during his or her lifetime is considered an overdiagnosed cancer. You can imagine that at the point of care, it's really difficult to distinguish what is an overdiagnosed cancer and what isn't. We don't have very good biomarkers to help us understand that at this point. Work is still being done on that. So estimates of overdiagnosis in lung cancer screening range from 10 to 20%, depending on the statistical method that's used to determine overdiagnosis. So in using the excess incidence method, overdiagnosis is around 18%, but then using microsimulation modeling, estimates are closer to 7 to 10%. And this is in contrast to estimates in mammography, in which a recent observational study found that the 10-year probability of an overdiagnosed breast cancer to be about 60%. So again, I mentioned that overdiagnosis is it's a harm that is shared by other cancer screenings, but not one that is really discussed among physicians or with patients. And that's in part because it's very abstract and we have certain expectations of our healthcare, and we have a lot of difficulty in identifying what an overdiagnosed cancer is. And then the overdiagnosis as a consequence of screening is not unique to cancer alone. So it occurs when there's screening for other conditions. So even things like diabetes and hypertension, there's going to be overdiagnosis of those conditions. But again, and these are things that we face routinely in the primary care setting, but is not often kind of discussed because the benefits in most cases or all cases outweigh the harms. So all of the harms of screening are considerably worsened if the screening criteria or eligibility are not optimal for detecting cancers in the individuals at the highest risk for cancer, because that means that the individuals are experiencing only harms and no benefit. So now I'd like to move on to talking about promising novel lung cancer screening criteria. So this was one of the first studies that helped establish that the benefits and harms of screening vary according to lung cancer risk. So this was a retrospective study of the NLST in which investigators created a risk prediction model that predicted the 5-year risk of lung cancer death. And they divided individuals into 5 quintiles of risk. So you can see that on the left here in this third column, which is quintiles 3 through 5, 88% of screen-prevented lung cancer deaths occurred among participants in these 3 quintiles. So these are the 60% of participants at highest risk. Whereas the 20% of participants at the lowest risk, so those are the individuals in quintile 1, contributed or accounted for only 1% of screening-prevented lung cancer deaths, which is pretty impressive in terms of how few lung cancer deaths those individuals are really experiencing. And then across risk quintiles, there were also significant decreasing trends in the number of participants with false positive results per screening prevented lung cancer death. And that there are also differences in the number needed to screen. So you can see quintiles 3 through 5, the number needed to screen to prevent one lung cancer death is 208 compared to all quintiles where it's 302. Excuse me. All right, so this is another study that supports that the USPSTF criteria misses a large percentage of the high-risk population. So this was a secondary analysis of the Framingham heart study and the offspring study, in which they looked at their lung cancer cases and they found that just less than 60% of lung cancer cases met eligibility criteria for USPSTF lung cancer screening guidelines, and that the individuals who were ineligible for lung cancer screening, but who developed lung cancer were these overlapping groups of former smokers who had quit more than 15 years ago, or who were outside of the age range, usually younger, or who had less than 30 pack year smoking history. And there's also troubling research that the poor sensitivity of lung cancer screening affects individuals inequitably and contributes to and worsens racial disparities. So this is a prospective study of about 48,000 ever smokers in the Southern Community Cohort study. And they looked at their lung cancer cases and they found that only 32% of the Black lung cancer patients were eligible for lung cancer screening according to USPSTF criteria, compared to white lung cancer patients where 56% were eligible. And that these differences in eligibility were primarily associated with fewer smoking pack years. So Black patients had a median pack years of 25 years compared to 48 pack years in white smokers. And this racial disparity was observed in both the sensitivity and the specificity of the USPSTF guidelines between Black and white smokers for all ages. So what these investigators then did was they assessed the impact of lowering the screening pack year eligibility criteria to a minimum of 20 pack year history instead of 30. And they found an increased percentage of screening eligibility of their Black smokers and equitable performance of both sensitivity and specificity compared with white smokers across all ages. So what is the role of lung cancer risk prediction models in all of this? One possible role for these models is to improve lung cancer screening so that it's more sensitive, so that the benefits are maximized and the harms are minimized. So lung cancer risk prediction models attempt to capture more of the complexity of lung cancer risk beyond age and smoking history. So these characteristics or categories are factors that are considered in the PLCO-M 2012 lung cancer risk prediction model, which includes not only age and smoking, but also family history of lung cancer, race and ethnicity, education, BMI, and history of COPD. So the question is, can alternate screening criteria using risk prediction models improve lung cancer detection? So this was this graph comes from the results of a study that was a retrospective single center analysis of a racially diverse population of patients diagnosed with lung cancer. And investigators compared the sensitivity of the USPSTF screening criteria with the PLCO-M 2012 lung cancer risk prediction model. And among all individuals, the sensitivity increased, so it went from 52 to up to 69. And there were more substantial or significant increases for Black individuals, but improvements in sensitivity occurred for everyone. And then another important question is whether these risk models improve the number needed to screen. So this means that risk models may improve the effectiveness of screening. And this was, you can see here that using risk-based criteria, the number needed to screen to prevent one lung cancer death using a particular type of modeling to represent US ever smokers, the number needed to screen went from 194 down to 162. And using this risk-based criteria, this is similar to the PLCO-M 2012 risk factors that are considered. So not only age and smoking history, but also BMI, family history of lung cancer, and self-reported emphysema. Investigators have also looked at the differing impact of using risk modeling thresholds for screening compared to USPSTF criteria across different age groups to understand who wouldn't get screened using the USPSTF criteria. So this was a modeling study. That means that they're using a kind of very sophisticated mathematical model. They're using population-based parameters when possible to look at kind of smoking history of a birth cohort, for example. And then they looked at the age-specific 6-year lung cancer risk for each individual between the ages of 50 and 90. And this graph kind of shows what they found. So the highest proportion of the population missed by the USPSTF criteria, so that's what these columns represent, occurred among Black individuals but at younger ages. So you can see here, this just reflects the fact that it kind of goes back to that retrospective study that I presented earlier, that Black individuals are diagnosed at a younger age. And so they're more likely to be missed by the current screening criteria. But that a significantly high proportion among all individuals were missed in older ages between 71 and 80 as well. So what do we do with all this information? We now have this lung cancer screening that's really well supported by the highest form of evidence that we have, the RCT, and now it's been implemented, but we find that it's not so sensitive and it's not so effective. So what we do is the USPSTF has now drafted new eligibility guidelines. So the age range, and obviously these are, or I meant not obviously, but these are draft guidelines, so they haven't been published. Officially, that's what I wanted. So the age range is now, I guess it's being proposed to be lowered to 50 from 55. And the pack year history is also proposed to be lowered to 20 pack years. And the hope is that this is going to reduce disparities in eligibility by sex and race and ethnicity, and that hopefully we will have a higher performing screening test. So now I'd like to move on to the fourth objective of today, which is to explore system, provider, and patient barriers to screening. So after we optimize the performance of lung cancer screening by changing the eligibility criteria, there remain system, provider, and patient level barriers to screening. So the first question is, are lung cancer screening programs available? And you might think that lung cancer screening can pretty much occur anywhere where there's a CT scanner. As we know, in New York, there's no shortage of those. But actually, individuals need access to a comprehensive lung cancer screening program. And that's currently a requirement for reimbursement by CMS. And it's possible that the low adoption of lung cancer screening may be explained by actually just low access to a comprehensive lung cancer screening program. So a comprehensive program includes a reading radiologist with specific training criteria, the use of a standardized lung nodule identification system, the provision of smoking cessation interventions, and then data submission to a CMS-approved lung cancer screening registry. And ideally, comprehensive lung cancer screening programs are distributed in accordance to screening needs. And this is because there's actually, geographically a lot of variability in the rates of smoking across the United States. And we tried to answer this question by conducting a geospatial analysis, cluster analysis, to look at patterns in lung cancer screening registry density, which we defined as facility per 100,000 persons at risk, looking at socioeconomic factors, looking at lung cancer incidence by stage of mortality, as well as preventive service use in the state population. So we found 3 clusters corresponding to the northern, southeastern, and southwestern states. And the states that are outlined in red here, these are the states in the southeast, they had the highest lung cancer burden, the lowest current total number of lung cancer screening registry facilities. And they also had the slowest increase in lung cancer, or the lowest increase in lung cancer screening registry facilities between 2016 and 2018. And while we don't know the optimal number of lung cancer screening programs per 100,000 individuals at risk, our results really do suggest that there's a mismatch between the need and available services. And of course, one of the biggest system level barriers to screening is coverage. So this map shows the Medicaid fee-for-service program coverage of lung cancer screening, updated as of September 2020. So you can see the states in blue. These are the states that cover lung cancer screening. So that's most states actually. And then the states in purple do not cover screening. And then 3 states didn't have any information about screening. And some of you may be thinking, wait, the ACA required Medicare and Medicaid expansion plans and most private health insurance plans to cover preventive services given an A or B grading by the USPSTF, which means that screening should be covered without cost sharing for patients with those insurances, which is true, but standard Medicaid is not actually included in that. So coverage of USPSTF recommended screenings is not required for standard Medicaid. And if screening is covered, Medicaid programs can use different eligibility criteria. They can also require prior authorization, or they can charge individuals for their scans. And that means that within one state, the coverage for lung cancer screening can vary between both a fee-for-service Medicaid and a Medicaid or a managed Medicaid plan. And this is particularly concerning as Medicaid enrollees are disproportionately at risk for lung cancer. 26% of Medicaid beneficiaries are current smokers compared to 11% of individuals with private insurance. So aside from system barriers to screening, primary care providers have also identified barriers they've experienced for ordering screening. And this is important because PCPs play a key role in ensuring the appropriate assessment and referral of patients to cancer screening services. Historically, healthcare provider recommendation has been the strongest predictor of screening uptake for breast and colon cancer, and is likely as influential in lung cancer screening uptake as well. So it is time for our first poll. Okay, let me see if I can get this going. Okay, so this is the first poll. What is the greatest barrier to discussing lung cancer screening? I'm going to see if I can get up to 60% participation and then close the poll. We're almost there. Okay, we're not there. We're not going to get there. One of you voted and then took it away. It's okay. So I'm sharing the poll results now. So most of you said that the greatest barrier to discussing lung cancer screening is that it's not yet routine. 33% of you, followed by competing health priorities, followed by discussions taking too much time, or that's tied with what barriers, it sounds really easy. And then lastly, forgetting to mention screening. So this is a little bit different from what a national survey of barriers found, which we'll move on to next. All right, so these are the physician barriers in a national survey of PCPs looking at knowledge, attitudes, and beliefs of lung cancer screening found. So the biggest barrier to discussing screening was competing health priorities, followed by discussions taking too much time, forgetting to mention screening, and then screening not yet routine. So a little bit of a flip from what you all identified. And then what about physician barriers to ordering screening? In the same survey, 2/3 of physicians identified a barrier to ordering screening, and they're really all about insurance. So, prior authorization requirements, coverage denials, lack of insurance coverage were the big barriers to ordering screening, followed by transportation challenges. And we know that in addition to kind of system and provider level barriers, there are also patient barriers. So there have been lots of studies trying to understand what are the patients' beliefs and attitudes about lung cancer screening. So this is a study which in which investigators conducted semi-structured interviews with individuals who were eligible for lung cancer screening, who were referred for lung cancer screening by their PCP, and then who didn't follow up, who essentially opted out. And investigators found these 4 major themes. So the first theme was knowledge avoidance, fear of the disease and treatment. There's also the theme of perceived low value, or both wasted effort and skepticism, the worry of false positives, and then also practical barriers such as time and cost. And then we also know that patient health beliefs also play an important role in how individuals manage their healthcare and which health behaviors they seek out. So studies of patient beliefs have found that patients find lung cancer screening to be inconvenient, that there's smoking-related stigma, or the sense of being blamed for having smoked or being made to feel like a social outcast that influences their thoughts about lung cancer screening. There is distrust of both the government and the tobacco industry. There's also some fatalistic beliefs, like if I get lung cancer, it's because it was meant to be, and spiritual beliefs that God will help me with lung cancer. So one way of addressing patients' concerns is through education and counseling. However, 1/5 of providers have found that lung cancer screening conversations take too much time, according to that national survey. And this is quite possibly because of shared decision-making. So does shared decision-making in lung cancer help or harm? Let's start first by just talking about why we're even talking about this with lung cancer screening. So shared decision-making is a unique feature of the CMS approval for lung cancer screening. And it had to include several different components, including using a decision aid and also counseling on smoking cessation. There are 3 essential components of shared decision-making. The first is recognizing the need for a decision. The second is understanding the best available evidence. And the third is incorporating the patient's values and preferences. And it's important, I think, to note that shared decision-making is not required for mammography or colonoscopy. And it's really at odds with other cancer screening recommendations for which we have as robust evidence to support the effectiveness of those screening tests. Generally, shared decision-making is commonly used or recommended in clinical situations where there's some kind of equipoise, which means that basically the benefits and the harms kind of are equivalent. And that's really not necessarily the case in lung cancer screening. So here are the steps of shared decision-making. So in the information sharing phase, the potential benefits of screening are discussed. The importance of follow-up is emphasized, as well as the harms of screening, including overdiagnosis and false positives and radiation. And then in the deliberation phase, a patient's preferences, values, and concerns are elicited and discussed. And then all of that leads to a shared decision of whether or not to undergo lung cancer screening. And this is recommended to be performed with the use of a decision aid. But we know from studies going back to 10 years earlier that providers don't necessarily buy into the model of shared decision making. So this was a very large survey that was conducted in the early aughts, which found that providers found shared decision making to be impractical. And they also found that there was lack of applicability due to the patient characteristics or the clinical situation. So unsurprisingly, shared decision-making is probably not occurring. So investigators, to answer this question, took a 20% Medicare sample in 2016, and they looked at individuals who had claims for low-dose CT, and they found that only 9% had a claim for a shared decision-making session in the 3 months prior to low-dose CT. And we also know that there are some barriers to shared decision-making. So in order to understand some of the barriers, investigators conducted semi-structured interviews with clinicians who had ordered lung cancer screening in the previous year. And then they also conducted focus groups with patients who had undergone lung cancer screening. And they explored the degree to which the participants or the patients' depictions of lung cancer screening discussions reflected shared decision-making. So here are some barriers that they found. So barriers to information sharing were that there are strong beliefs in the benefits, which is not surprising given the evidence to support it, and the providers assuming that patients won't understand, which is just a reflection of kind of, in some cases, just a paternalistic attitude. Here are some barriers to the deliberation, which is that assuming that the patient doesn't want to deliberate, or providers expressing some discomfort with navigating a patient's emotions, and then the patients feeling pressured to deliberate. And then overall, barriers to the shared decision of competing demands, which we learned earlier from the National Survey of Barriers to Discussing Screening, that shared decision-making takes too long, and that providers have discomfort with the skills of shared decision-making, which isn't surprising because I don't think this is routinely kind of taught in medical school or residency. So it's not clear to me that shared decision-making is necessarily a barrier of lung cancer screening, although we know that there are barriers to shared decision-making. So I'd love to, when we have time at the end, which we're actually very near the end, is to have a conversation or learn from you what you consider to be some of the barriers to lung cancer screening. I think it's interesting that most of you identified that lung cancer screening is not yet routine as one of the biggest barriers. So I'd like to learn a little bit more about that. But let's do one more poll. All right, so there we go. Can everyone see the poll? Great. Okay, there are 3 questions for this poll. All right. I think I had higher participation in this poll, so thank you very much. Got up to 54% of you voting. Let me share the results. So now you can see the results. Most of you report that you have done shared decision-making in the past, 62% of you. Let's see, about your split between agree, or you all basically agree that shared decision-making is useful. Some of you thinking it's strongly or very useful versus slightly less, or strongly agreeing rather. And then let's see, slightly more than 50% of you see light at the end of this tunnel regarding the pandemic. A quarter of you find that the variants keep you up at night. A quarter of you says, who knows? I echo all of these responses. Thank you for participating. All right, so I would like to conclude. So I think what I've shown you is that lung cancer screening adoption is low, that the current USPSTF eligibility criteria is not optimized to maximize the benefits of screening and may actually be contributing to racial disparities, that there are system barriers of coverage, insurance coverage, and prior authorization requirements, that there is limited availability of screening programs for high-risk populations, that there are provider barriers of time constraints and the newness of screening, patient barriers of low perceived risk, fatalism, and stigma, and that the role of shared decision-making in lung cancer screening at this point is unclear. So I would like to thank my mentors and colleagues, as well as my patients at IMA, and my research is funded by the American Cancer Society and the NIH. So I'd love to have time for questions, conversation. As I mentioned, I'm very interested in learning from you why you feel like screening is not yet routine in your practice. So if anyone wants to chime in about that, that would be, to get us started, that would be great. I'm going to go ahead and stop sharing my screen as well. Okay, that's fine. That's also fine.
Thanks for that talk. I will open the floor to questions in general, I guess, if people want to unmute themselves or enter them in the chat. And maybe since most of the people on this call are Sinai affiliates and mostly ordering through Epic, and since it sounds like people agree that shared decision making is useful and ordering lung cancer screening is useful, could you just talk through the process a little bit about like literally how to order it through Epic and how often to sort of order it and manage it directly versus taking advantage of the system lung cancer screening team that's based uptown?
Yeah, so sure, happy to. Right now, there isn't a very good systematic process for determining lung cancer screening eligibility. I'm sure many of you know that there's no healthcare maintenance for lung cancer screening for eligible individuals, and that sadly our percent of missingness and smoking history in Epic is pretty woeful. So, it's real. The onus is really on providers to remember to determine lung cancer screening history, or smoking history. And that really starts with the kind of the questions that are a part of the Epic field right now about smoking history, but then kind of teasing out, okay, does that actually equal 30 pack years? I think in most cases, providers are just doing the best they can in terms of, a person who says like, oh, well, I started smoking and then I stopped and then I increased and then I stopped again, and they just kind of put it together. So if that person meets the current criteria of 30 pack years and the age range of 55 to 80, then the next step is really putting in the order for the low dose CT. And then at Sinai, the system or the screening program actually has, they perform the shared decision making. So they will go through with a decision aid, go through the benefits and harms of screening and offer smoking cessation. What I'm actually hoping to do in my research is to create a decision aid in Epic so that providers can do that process themselves, because I think there's a little bit of bias when the shared decision making is being performed by, essentially the radiologist team who's going to be doing lung cancer screening. That said, I think that it's the fact that shared decision making is recommended for lung cancer screening really reflects some stigma around smoking or screening, or bias on the part of interpreting the results of the RCTs that support lung cancer screening benefit. So that's a side note.
So it sounds like people have the choice to do the shared decision making themselves and order the test themselves, or to send people to uptown and they'll take care of the shared decision making, but then it's an extra visit for the patient, either a real visit or a video visit, to like go and have that conversation with them.
Exactly.
Dr. Berger, you look like you unmuted yourself.
Yeah, I was going to ask a question around, so you made a comment and went into some analysis that showed that maybe we'd be better off by 20 years because this would increase sort of who gets screened, and that by increasing that it would become more in the forefront of our mind and maybe do better than even for the higher risk 30-year people. But despite that analysis, the CMS guidelines are sticking with 30. And as you point out, one of the big barriers is, of course, variable payments and all these other, it's a complex system. So do you believe, like, I sort of am unclear if you think that should be pushed further into the payment realm, like, yeah, 30 is good, but we could do better if it's 20. And yeah, there will be a few more false positives, but we'll probably catch a whole lot more people. And then we know over the last week, there's been a lot of lay press stories about how our biggest gains in lung cancer are actually in the non-smoking population.
So I think that if the USPSTF draft recommendations get approved, I think CMS will actually follow suit, but you're right, there are trade-offs. So the hopes is that it will become more equitably sensitive for all of the individuals at risk, but how that actually gets implemented and where we end up seeing those benefits remains to be seen. But there are definitely going to be some trade-offs in terms of the false positives or the number needed to screen when we change the threshold. I think we should actually strive to push for a more risk-based approach beyond age and smoking. And I know that also increases a lot of the effort of providers to determine what their risk is. And I think historically risk calculators aren't really kind of embraced widely at first, but if we can, if we have anything to kind of tell us that there's room for that, is to think about the adoption of the ASCVD risk calculators, which I think have been really widely adopted, and they're, easy dot phrases that help you calculate that and use that when you're talking to patients about primary prevention of CAD. So I think that there's definitely room for that, and that ultimately is going to get us the kind of the most effective screening.
Excellent.
Thank you.
Sure.
Other questions?
Thanks for the question.
I guess then I'll throw out another one, just
Sure.
or more an idea, which is I don't even understand if the barrier is this sort of shared risk discussion or other things. I agree with you. I think it maybe what we think of it is a longer conversation than what really needs to go on.
Mm-hmm.
As you point out that there are a number of electronic tools, why are we not, if we have the data in Epic, who we should reach out to manually, why are we not pushing this out as sort of a question, a survey, let them fill it out, and then see whether or not they even need that discussion, rather than sort of calling them or triggering them using electronic notices and sort of putting it on their table, and then allowing those that are, at least for lack of a better term, the easy money or the low hanging fruit, right? High impact, low cost kind of people to opt in and move the ball by getting that sort of going. And then we can work more on people that require perhaps more convincing, who will have benefit from it in catching cancer if we believe in this. It seems like we're still trying to do things in an analog way in a digital world. I think Martin's going to try and weigh in as he popped onto the screen now.
No, it's a good point.
Yeah, so thanks for the presentation. What was the absolute reduction in risk? I think it was a 25% relative reduction.
So NLST found 20% and Nelson found 24%. Absolute's more like 3%.
3%.
Mhm.
So if using some of the models, it seems like if you screen 1,000 people over a course of several years, you save 6 to 8 lives.
Mm-hmm.
No, it's if you're one of the 6, it's a tremendous benefit, but it's a lot of screening for folks who aren't going to benefit, and to the point where there's lots of competing demands. Just wonder if system-wide there's a way to take the tracking and ordering and off, either built in some decision support into Epic to facilitate that, or to take some of the work off the providers, and because remembering to order it every year and every 6 months becomes a logistical issue.
Mm-hmm. Yeah, absolutely. I mean, I agree with both of you that there needs to be system level interventions to take the burden off of providers. And I don't know where, the clinical informaticists at Sinai are in terms of pushing out surveys using MyChart. And we know that during this pandemic, we've had increases in MyChart adoption, telehealth adoption, but how that's being used to kind of create more, I guess, benefits for patients for preventive care, it's unclear to me. I think there's in general like a reluctance to push out things like that because they don't want to scare patients, is my sense, or kind of like make it seem like now it's a burden on patients to fill out a survey or to, put in their smoking history. My first thought was let's send out a MyChart and get everyone's smoking history who has MyChart. And I I don't know who the powers that be are who could make that happen. I'm not one of them. But yeah, I think that there are some definitely low-hanging fruit and that we need system interventions. Absolutely.
Almost like a registry. You could have a registry of people who are eligible, who's gotten screened, when their next follow-up visit's going to be, whether it's 6 months or a year.
I
To
think
help.
the first barrier is just figuring out how to deal with the missing smoking history, because we really just don't know who's eligible, who isn't currently captured in EPIC.
Martin, are you one of those powers that be?
You know,
Can
there's
we find a way offline to like push this issue a little bit?
well, I know there's an effort to relook at some of the BPAs that Joe Cannery's been involved with, and you know, so there's I think there's no shortage of demand being placed on the EPIC transformation team.
Yeah.
But you know, coming up with a better way to screen for tobacco use seems like that should be something that can be built into EPIC and sent, you know, whether it's, you know, somehow done more efficiently. Because it does, your comment that they stopped smoking, started smoking. How do you calculate that into the overall 30-year, you know, is time consuming. And
yeah. I mean, I'm proposing, so I'm actually talking to Joe Cannery later today. I'm going to bring him onto my team for, you know, creating a new intervention around this. And, you know, he's like, I want you to put together a wish list. So one of my items on the wish list is to just simplify the lung cancer screening questions to align with how lung cancer screening history is determined in a lot of these, you know, national surveys, which is basically, how old were you when you started screening? If you quit, what age did you quit? And on average, how many cigarettes did you smoke per day? And then patients will give you those numbers, and then the work's done. And we don't have to think about all of the, you know, vagaries of someone's smoking history. But as it is in EPIC, which is not that, you kind of, the patients will give you an age, and you got to calculate the date, and then you got to put that in, and it's a mess. And according to Joe Cannery, those fields cannot be edited. They come with the EPIC build, and there's no little support for them. So I don't know what that means in terms of fixing it. So we'd have to have a whole new process, which would then be like a duplicate of what's already there if that can't actually be dismantled. So yeah. All right. Well, thank you, everyone.
thank you very much.
Thank you.
Thank you.
This is delightful.
Sure.
All right.
Thank you.
Be well, everybody.